Hi, thank you so much for having me. My name is Sonia Okuyama. My pronouns are she, her, hers. I'm a medical oncologist, division chief at Denver Health. Our practice is a community oncology practice. We do bread and butter oncology, but we also have our challenges based on the practice setting and the patient population. Oh, I have it here. I didn't know. Great. So today I'm going to talk about hereditary cancer syndromes and just a little bit more of the practical approaches and the things that we have learned in our institution as trying to lift this program up from literally thin air. We will start with talking about risk factors for cancers, talk a little bit about the pathophysiology behind hereditary cancer syndromes, the implications for our patients in particular, and some practical considerations in trying to get this going. I do not have any financial conflicts of interest to disclose. However, I do want to point out I am a medical oncologist. I'm not a geneticist. I am not it's not my area of expertise necessarily. My area of expertise is the underserved patient population that we take care of at Denver Health. My expertise is in the health systems and just building oncology programs. We do have fantastic experts among us, primarily the genetic counselors that you may have available, or there are other oncologists who also do this with more detail. For example, Dr. Marie Wood at the university, Dr. Kathy Klein. Those are the real experts. So here are the risk factors for cancer. Most commonly is bad luck or chance, being older, the exposure such as tobacco, HPV, contaminated air, for example. But the other big one is genetics, and that's the one that we will talk about today. Now, the genetics that I'm talking about is not going to be about the mutations that you find in the tumors. It's really about what people inherited or were born with that predisposes them to later develop cancer. And how many of our patients will have an inherited mutation? And depending on the data set that you look at and depending on the specific cancer type that you're taking care of, it varies a lot. So ovarian cancer being the highest one, about 1 out of 5 patients will have an inherited mutation. And then even an acute leukemia patient can develop this because they were born with some predisposition. And so stomach, breast, all of those that you see up there have a pretty high it's significant, the amount of patients who may have an inherited mutation. The pathophysiology behind this is the two-hit hypothesis. So basically, for a cell to become cancerous, you typically will need 2 abnormal genes. Then the genes are the tumor suppressor genes or DNA repair genes typically. So you first have one gene, each gene, you have 2 genes that you're born with, one from each parent. One of them, if one of them gets mutated, by chance, nothing typically would happen. But then if the second one gets mutated, then that cell becomes a cancer cell. But if you are born with hereditary cancer, you are born already with one of them mutated. So you only need one extra mutation to then develop cancer. And that's why it just happens more frequently. And here's a non-exhaustive list of the different syndromes that we can deal with. These are grouped. So the most common ones are the hereditary breast and ovarian cancer syndrome caused by, not just BRCA1 and 2, which are the ones that we're most familiar with. There are other genes that are also involved in this syndrome. And that's associated not just with breast cancer, but also ovarian, prostate, pancreas, and melanoma. You also have Lynch syndrome is the second most common one, and that one is also known as a hereditary non-polyposis colorectal cancer syndrome, and there are a list of genes that are associated with this hereditary cancer syndrome, and then there's other ones listed there as well. So here is a table where you can see, for someone, for example, with a BRCA1 mutation, what are the risks of developing different types of cancer? So a female with BRCA1 will have, up to 72% risk of developing breast cancer up to age 70. It's a little bit less for BRCA2 mutations, an ovarian cancer, and prostate, breast in male, and pancreatic. So here you can see it's not 100%, but it's significantly higher than the general population. And here are the implications for a patient who we know has a hereditary cancer syndrome. So hopefully you identify, not you, I would say the primary care clinicians are identifying these patients before they get cancer. And so these patients need a completely different screening strategy. They are not going to be starting mammograms in their 40s. They're going to be starting a breast MRI in their 20s, and then add on the mammogram in their 30s. And so it's very, very different, more intensive screening because of their increased risk of cancer. We talk to them about risk-reducing mastectomy. They need to see a breast surgeon to talk about the possibility of taking those breasts off. To decrease the risk of ovarian cancer, they also are recommended risk-reducing salpingo-oophorectomy, and that's highlighted up there in the top. And also just their medications that they can consider and things like that. For us who see patients who already have a cancer diagnosis, it has such huge implications in how we treat these patients. So a patient who has breast cancer and has an underlying BRCA mutation, we would not recommend a lumpectomy. We would recommend a mastectomy. And so, we need to know pretty early on within their diagnosis, do they have the mutation or not, so that we can actually tell them what are their real treatment options. If someone also has that BRCA mutation, we may want to use certain medications as part of their treatment plan. For example, we can use PARP inhibitors in metastatic breast cancer, or in a patient with ovarian cancer, we also use PARP inhibitors for maintenance therapy. There are real implications of what we do with a patient in front of us if they have or they do not have a hereditary cancer syndrome. And here is my single curve to be also called an oncologist. And this one is the slide of the Olympia trial, which enrolled patients who have a BRCA1 or 2 mutation with high-risk breast cancer, and high risk determined by certain clinical criteria that are listed there, and how adjuvant olaparib for these patients actually help them live longer. And from the NCCN guidelines, you see very clearly how things start breaking apart in how we treat our patients, whether they have a mutation or not. Again, primarily PARP inhibitors for patients with metastatic breast cancer. And then this one also, it's for triple-negative breast cancer. If they have a BRCA mutation in that second arrow, we will recommend PARP inhibitors for second-line therapy instead of chemotherapy. Oh, I don't like this. This is a slide depicting the different types of cancers that you can see in a patient with Lynch syndrome. So Lynch syndrome was typically associated with colon, but always remember endometrial is another big one, but that's not the only one. There's many other syndromes many other cancers that are associated with Lynch syndrome. And for the sake of time, I'm not going to go into too much detail like I did with the HBOC BRCA just now, but just know, that there are, direct implications of treatment for our patients with Lynch syndrome. And I couldn't help myself but add this slide. Again, for me, diversity, equity is just so ingrained in everything that we do. Identifying a patient with a hereditary cancer syndrome, the equity implications of that is huge, right? Because you're not only helping determine what is the best treatment for that one patient, you are going to really, hopefully, identify a whole family tree who is at risk for cancer. And if we are able to then find those patients who have the syndrome and are not yet diagnosed with cancer, we can help them make sure that they never get cancer. And so that whole family tree gets benefited by us identifying these patients. So never forget that part. All right, so let's get testing. So whenever we said we want to get our patients tested, the challenge that we had was that a lot of our patients didn't have access to these services when they were not in-house at Denver Health. So, we started working on all of that, and these were the items that we had to go through: who to test, how to test, what test to order, and how to explain the results. Because all of that I had to learn to do myself out of the seat of my pants. The problem about who to test right now is it is a moving target. And we have to be careful. So for a patient with cancer, all of the tumors for colon and endometrial cancer should get a screening test called MSI, or microsatellite instability. And I think most pathologists know that they have to do that, but if in your particular program you see a patient with these cancers, just make sure that that gets done. Because if a particular tumor is MSI high, then the next step is to make sure that this is not driven by Lynch syndrome, and these patients need genetic testing. So that's one big category. The other big category of patients with cancer that you will want to consider testing are those that say you send a tumor to Foundation or some other company to get sequenced, and then in that sequencing result, it tells you, oh, the tumor has BRCA. So a pancreatic cancer sample that has BRCA mutation, it has implications on what you're going to treat, but then the next step is going to be, is that BRCA from the tumor, or actually is it that the patient was born with it and the patient has a hereditary cancer syndrome? Because then, once again, you want to chase the whole family tree after that. So that's another one. And the companies who do sequencing of the tumors are really good about spelling that out and telling you, this particular mutation could be germline. Make sure that you are doing genetic testing next. So that's the second next category. And then the third category, which is a moving target, which is very frustrating for all of us, are based on guidelines. There are many, many guidelines. The ones that I use, of course, are the NCCN guidelines, but there's other ones as well. And the problem is that they are very different. So for example, here is onto the right side of the slide, you have, this is what the NCCN guideline tells you we should be doing, or who we should be identifying to do genetic testing in a patient with breast cancer. So anybody who is young, who has triple negative breast cancer, who has certain combination of clinical characteristics and family history. So, complicated, but it's there, it's spelled out. If you look at the guidelines from the American Society of Breast Surgeons, their recommendations say test everybody. And so if you work in a clinic with this breast surgery team, you probably will have, I bet the surgeon's going to follow those guidelines, and then the medical oncology team is probably following the NCCN, and they're probably, they just need to talk to each other and come to a consensus. What is real in terms of consensus, every single patient with ovarian cancer should get genetic testing. All patients with pancreatic cancers should be genetic testing. Breast cancers, all of them according to the surgeons. Colon cancer is also changing. The NCCN guidelines just changed sometime this year. Before it was the young patients, MSI high or whatever, and just recently they are changing to everybody. And so my fear is, what about those colon cancer patients that I didn't test 10 years ago because the guidelines are old? They're already out of my practice. They completed their 5 years of surveillance. They're out in the world. They never got tested. And that anxiety, just, again, it's real. And how if you had that same patient now, you would be giving them genetic testing. Patients with prostate cancer who are metastatic or high-risk histologies, patients who have 2+ cancers, and depending on family history as well. So those are the things. This study was interesting. Mayo Clinic sequenced 44,000 patients, and they realized, and sequenced like the genetic germline, and 40% of the patients that they identified having a hereditary cancer syndrome did not meet any NCCN guideline criteria for even being tested. So that just tells you how bad the guidelines are, and they're trying to get better, and the guidelines are changing. And again, why was it that all these guidelines were placed to begin with? It was testing was expensive, resource intensive, all that type of stuff, but that's not the case anymore. It's quite easy nowadays, so it might not be too much of an issue. And I'm running, I need to start going faster. Yeah, and so all these guidelines might be a non-starter because now it's available, right? You go to Amazon and you get the 23andMe testing. Now that is not a comprehensive list of genes, just FYI, and it's a non-CLIA certified lab. So anything positive from there needs to be repeated in a clinician's office. And then you can go to Invitae's website and for $250 get an actual real panel. So, whether you need to worry about things following guidelines or not, not as important anymore. I'm stuck here. Is it because I ran out of time? Yeah, no. So in the interest of time, there are just two things. Oh, okay. All right, and then you can sign up for this All of Us research program where basically they're trying to get everybody sequenced. Here, I just want to make sure anybody, in theory, can do pre-test counseling. So in our brains, we're like, oh, somebody needs genetic testing, let me find a genetic counselor. So that's not true. Any one of us who has this expertise in this can provide pre-test counseling, and including oncologists, that's why I was doing it, a nurse, or any other professional with expertise. And we basically, in the pre-test counseling, you teach them about the risk factors of cancer, and you go through all of this and decide on the testing and that type of stuff. So it's not, again, how did I learn? I was basically studying the notes that I got from the patients that were insured and were getting testing. And so the note that I got back, I was looking at those. I was basically reading with the patient the little patient-facing education that these companies have, and just reading it through with them, and basically they go through all of this. So it can be done. You can take a course. The City of Hope training is well recognized, and it's $2,000, and hopefully you have a supervisor or leader as nice as me who will pay for it and make sure you do it under the hours of that you are working, and you're not having to do it at the odd hours that nobody has. But that's also available. There's a completely online option. And then this thing. So why is it that we are losing our genetic counselors or the services that I know several of you guys had access to these and suddenly they disappeared? And it's because they are non-billable providers. They cannot bill. So if they cannot bill, right, then basically it is paid for by the profits of the other services. And we know just the healthcare system is all sorts of messed up, and those profits are going down. And so it is a problem. And in the end, who is most affected by it? And are those places that are not making money and don't have the extra profits to invest in these resources. And so there is a bill going through the state and at the federal level trying to make genetic counselors a provider by Medicare, so that then their services are billable, and so then it might be easier to build these programs. So just so you know, because I know several of you are pretty active in the legislature and advocacy. And because they are not providers, the test needs to be signed by us. Like the genetic counselor who actually knows the most about these testings, they cannot actually order the test, just so you know. And for me, that blew me away. These are the results. Yeah, no, that's all. I think I'm good with what we have. Happy to take questions.
Does anybody have a question? No? Oh.
Do people need to buy their life insurance before they get
Did you hear that?
Yeah, there's supposed to be language where you are protected, but it's not solid. It's not solid. Oh. Yes.
Without a family history of any cancers, do you still recommend people getting genetic testing? I mean, it seems like you would, based on your presentation.
So again, the guidelines do not support that. Am I tempted to spend $250 to get that testing myself? Yes. I think it's changing. It might be, right? This whole field is changing. More and more people getting, yeah, I can say probably not. The official answer is not. If you don't have family history, the official answer is no. Those who, people who do meet criteria without family history are those who are adopted. They are okay to get tested. Mm-hmm.